Hi Pediatric Squad, welcome back to the channel. So today we talk about a very important topic in pediatrics. It is pediatric hypertension. Before I talk about everything, I want to talk about two key takeaways in this video. If you forget everything about this video, do remember these two concepts. First, pediatric blood pressure, we need to think in percentiles, which is in different age, different heights, they will have different definition of hypertension. For those less than 13 years old, it's not in absolute numbers. For those who are older than 13 years old, we have absolute numbers. So do remember, do think in percentiles. Let's say blood pressure is 110/72. It's normal in adults, but in a 5-year-old, it's not normal. It's hypertension. So we need to check in the percentile. This is the first concept. The second concept is we cannot overlook the cause. We need to find out why the children is having hypertension, because it's often secondary to some underlying conditions. How should we find out? Go back to the basic: history, physical examination, and investigation. So these are two takeaways. Do remember this throughout the whole video. So the framework of this video, first we talk about definition, then we talk about assessment tools and how to confirm the hypertension, what are the secondary causes, and how do we evaluate, and finally, how to treat it. What is the definition of hypertension in children? As I said, before 13 years old, we need to think of percentile. So normal blood pressure is below 19th percentile, all right? Elevated blood pressure is between 90 to 95. Stage 1 hypertension is greater than 95 percentile to 95 percentile plus 12 millimeter mercury. So stage 2 is 95 percentile plus 12 millimeter mercury. All right? So just try to remember this. 95 will be the magic number. For children greater than 13 years old, it's more or less the same as adult. Normal BP will be less than 120 and 80. Elevated is 120 to 129 and less than 80. Stage 1 is 130/80 to 139 to 89. So stage 2 is more than 140/90. Basically, my video is mainly based on the 2017 AAP Clinical Practice Guideline on Pediatric Hypertension. This is one of the table shown in the paper. This is a girl's table. Let's say the girl is 4-year-old. According to their height, you will find different references for the 90 percentile and 95 percentile. Do take references. If you think it's quite troublesome to find out the paper, I would highly recommend using some apps. On the App Store, there are many pediatric blood pressure guide or calculator. This is one of the app that I recommend. Personally, I don't have any connection with the developer. I need to declare that in real life, I use this. I find it's very useful. You may check this out. Basically, you can just input the age and the height, and they will show you the percentile. But of course, there are some other apps you can try out. Just make sure they take the right reference. It's okay. Let's say in the clinic, you had one blood pressure findings which is quite high. So what's the next step? We need to repeat it until we confirm the hypertension. All right. So for blood pressure, usually it takes 3 visits. I need to emphasize that the most accurate measurement of the blood pressure is actually using your stethoscope. Use the always auscultate on your arms and then take a manual blood pressure. So you should do it twice more and then take average of 2 readings. If it's still elevated, repeat it in 6 months and then in 12 months. So if still elevated, you need to do some basic workup and consider referral. Of course, you should order ambulatory blood pressure monitoring, which is 24 hours blood pressure monitoring to confirm it. For stage 1 hypertension, also you need 3 visits. So first, guidelines suggest you recheck the blood pressure in 1 to 2 weeks, especially do both arms and one leg to rule out coarctation of aorta, because in coarctation of aorta, there can be significant difference between the arm and also the leg. So if it's still stage 1, repeat in 3 months. If it's still hypertension, again, do ambulatory BP, start working up and refer or treat it. So if stage 2 is more severe, we only take 2 visits. Measure all the extremities again, rule out coarctation of aorta, repeat it within 1 week. If it's still stage 2, do the full diagnostic workup, do the ambulatory blood pressure, and start treatment and refer. So these are how should we confirm. Of course, if the patient is having very symptomatic or the blood pressure is very high, or the patient you think that there's also already hypertensive emergency or urgency, do admit the patient and do the workup immediately. Don't wait for another visit. So what are the secondary causes of hypertension? Again, I need to stress on we need to think of the secondary cause and find out the cause of why the patient has the hypertension. Most common cause will be the renal cause, like chronic kidney disease, like history of glomerulonephritis. So basically related to the kidney. Secondly, we need to think of renal vascular causes, so i.e. renal artery stenosis. It can be congenital. When should we suspect that? When you're having a very high blood pressure, let's say stage 2 hypertension, and also significant diastolic hypertension. And if you do the ultrasound, you discrepant kidney size because maybe one renal artery is more narrow and have inadequate blood supply to one of the kidney. And of course, in RAS, you can have hypokalemia and also very young age. Thirdly, as I said, cardiac cause. The most famous one will be clogged tissue of aorta. So the right arm blood pressure will be 20 millimeter mercury higher than the lower limbs. So it's very important to measure both upper limbs and lower limb to rule out this. And other things will be the endocrine cause. We do have cases like pheochromocytoma, congenital adrenal hyperplasia, which will have ambiguous genitalia, chronic steroid use or Cushing syndrome. The patient may look Cushingnoid, the face may be quite chubby, abdominal dry, etc. Thyroid or parathyroid disorder, so do look for hyperthyroidism symptoms and also any goiter. And other causes, it can be like environmental or toxic exposure, such as lead, mercury. So another cause will be drug-induced. Do think of this in those adolescents. They can have some recreational drugs, or sometimes it can be like nasal decongestion. It can lead to hypertension. Genetic syndrome like neurofibromatosis type 1. In these kind of cases, as they may have cavernous spot, they may have neurofibroma, etc. Obstructive sleep apnea. Do think of this when the patient has snoring or very obese. How can we know about the underlying cause? As I said, history, physical examination, and investigation is already right in every kind of condition. So history. Firstly, you need to take a detailed perinatal history. Any NICU stay, any umbilical catheterization, because sometimes when you did the UAC, it can lead to hypertension later on. Nutritional history, especially for those obese patients. How is the salt intake? How is the eating pattern? Is it high fat or not? Social history, any substance use, any stress, any depression, this can also lead to hypertension. Of course, any family history of hypertension, renal disease, and endocrine disease or cardiac disease. So do think of the questions that based on the secondary cause that I've told. Do ask about the symptoms. For example, kidney disease, ask about gross hematuria. So for physical examination, similar to everything in pediatrics, growth is very important. Do see the growth chart to see if the patient is obese. If the patient is obese, sometimes it can be just primary hypertension instead of having secondary cause. Secondly, do the cardiovascular examination. As said, falling BP measurement, very important. Heart murmurs sometimes can be tissue of aorta. Feel the femoral pulse. Sometimes in older children, you may feel the femoral radial delay or the weak femoral pulse. Abdominal examination. Do palpate the abdomen to see any bilateral kidney. Listen to renal breaths to rule out renal artery stenosis or palpate for any abdominal mass. For other system, go back to the secondary causes. For hyperthyroidism, like goiter, NF1, cavernous spot. Do a genitalia examination to rule out congenital adrenal hyperplasia. So everything is based on the differential diagnosis of the secondary cause. Do remember the secondary causes. So what's the next step? The next step is after we confirm the blood pressure, do the history, physical examination, we do the investigation. Most patients should undergo 24-hour ambulatory blood pressure monitoring. The medical staff will give the patient a portable machine, keep measuring their blood pressure throughout the day. Why is it important? Because it can confirm true hypertension. There's an entity we call white coat hypertension. Basically, it means the patient will only high blood pressure in the clinic, but it's normal at home. So the definitions will be the blood pressure more than 95% in office, but normal outside. And other good things about the ambulatory blood pressure monitoring is to identify mass hypertension, which means they have a normal office blood pressure in your clinic, but then it is elevated in the ambulatory blood pressure monitoring. It's important because for some kind of condition like chronic kidney disease can be associated with mass hypertension. So after we do that, we confirm the diagnosis of hypertension. How should we further proceed? As I said, think of the differential diagnosis. Most common condition will be kidney condition and also obesity, right? So kidney function is important. Lipid profile is important. Do the urine analysis to look for any proteinuria and microscopic hematuria. So another will be the cardiac cause, like coarctation of aorta, right? So the second step we'll need to consider to do the echocardiogram to look for coarctation of aorta. Also, we can look for any left ventricular hypertrophy, because if you have high blood pressure, the afterload will increase, and so your left heart will pumping quite hard to overcome that increase in the afterload. So the LV will increase in size. Echo can assess this and look for any complications of hypertension. And also, if the echo shows left ventricular hypertrophy, it means that the high blood pressure may last for a bit of time already. So if you are suspecting RAS, let's say the patient has hypokalemia, or let's say if you can hear the renal brewery, or let's say the blood pressure is very high, do renal ultrasound with Doppler. It can show the RAS. Of course, renal ultrasound can also show you some renal pericardial disease. So if this is inconclusive, or those patients are obese, or if you really think suspecting RAS, the chance is high, remember to do the CT angiography or the MRI angiography. So some second-line tests, again, go back to differential diagnosis. For pheochromocytoma, save the urine catecholamine. For overweight patient, save the HbA1c and liver function to look for fatty liver. If you're suspecting hyperthyroidism, do think of thyroid function test. Drug screen if you think the patient has the recreational drug use. If you think the patient has OSA, obstructive sleep apnea, do the sleep study. If you think of the patient has RAS, do the renin-aldosterone ratio. Kind of also suggests that when not to over-investigate. Although I know I've said that most do think of secondary causes. But then if the patient, the children is greater than 6 years old, if they have positive family history of essential hypertension, plus they are overweight or obese, plus they do not have clinical features suggestive of secondary hypertension, and no laboratory abnormalities initial screening, let's say the renal function is normal. For these patients, very likely it is primary hypertension due to obesity or strong family history. For this patient, you don't need to exhaust all your investigation in order to find out the cause. So how should we manage? Our target is make sure the blood pressure is lower than 90th percentile. If you are greater than 13 years old, make sure that it's lower than 130 and that blood pressure lower than 80. Common sense. First line would be non-pharmacological treatment. Diet, you eat healthily, like high in fruits, vegetables, or we call it DASH diet, limited to salt intake and sugar intake. So, common sense. Exercise and weight management. When to start the antihypertensive medication? So, it's a big deal for children to start antihypertensive medication. So, these are the indication. For example, persistent hypertension despite lifestyle modification. Secondly, of course, symptomatic hypertension. The blood pressure is very high. Sometimes you can have headache, visual changes, dizziness. Of course, very high blood pressure, you need to start the antihypertensive, like stage 2 hypertension without a clearly modifiable factor like obesity. All right. And any hypertension with chronic kidney disease or diabetes, or if the patient has target organ damage, for example, the left ventricular hypertrophy. So that's why echo is quite important to assess the complications. So what medication should we start? You may have heard of A, B, C, D. So A is ACE inhibitor. So do remember it's contraindicated in pregnancy. Do counsel the adolescent girls about this. Example like lisinopril and allopril. B, beta blocker is commonly used in adult. But then actually beta blockers are generally not recommended as initial treatment in children because they have broader side effect profiles, such as exacerbation of the asthma. So secondly, for C, long-acting calcium channel blocker. Good example would be amlodipine. It is relatively has less side effect. D, diuretics. So usually we recommend to use thiazide diuretics. For example, hydrochlorothiazide. So do remember 2 key takeaways I need to repeat again. First, think in percentiles. It's not like adult for lower than 13 years old. The definition of hypertension, it depends on the percentile. Secondly, do find out the causes. Usually, it's often secondary to underlying conditions. So thank you for watching this video. If you enjoy watching this kind of video, do subscribe Paediatric Squad and do comment to leave your thoughts and any questions or experience in the comment section. And hopefully you can join our community by subscribing my channel. So if the channel keep growing until a point, I may establish some interactive platform like Discord or Patreon. So stay tuned. I'll see you in the next video. Bye.